Okay, well, thank you very much for the organising committee for inviting me. It's a pleasure to be over here in New Zealand and see so many local faces. I think what people and families with TS want, they just want to get on with their lives. They don't want to be medicalised. They don't really want to be involved with all these health professionals, and many people with TS actually don't need a lot of involvement, which is good. But what they do want is they want to, when they are involved with health professionals, they want people who know what they're doing, and they want them to have knowledge. They want them to understand the condition, and if they don't have all the answers, they're prepared to go and either look things up or educate themselves and go on that journey with you. And what we've found with setting up the TSC clinic at Sydney Children's Hospital is a lot of doctors within the hospital were seeing individuals and their families with TS, but they weren't really talking much. And so a lot of neurologists, they would have a sort of handful of young children and adolescents with tuberous sclerosis, mainly because they're having seizures. Not everyone will have seizures, or the seizures will settle and then they're not really a problem. So really, a lot of these doctors are seeing individuals who are more severely affected, and it's important to realise that's not always the case. And so medical profession have a very biased view about what TS is, and I'll talk a little bit more about that. But what happened when we started the clinic is that all the patients with TS were seen by one neurologist, and that enables everything to sort of run a lot more smoothly, and there's more consistency, and it means that neurologist upskills, starts developing collaborations with overseas groups, and so you just up the skill level. So to me, it's very important to have individuals within a country who are really knowledgeable. Not every doctor can be knowledgeable, but they have to be willing to be either educated by families and educated by other professionals. But you do need people who are interested, and so it's fantastic you put together a program with local specialists who actually, just the fact of coming to the conference and hearing what you guys say is actually a way of them sort of just accepting that they actually are on this journey with you guys as well. So that's enough of me just going on about rabbiting on. So I'm just going to give you an overview. Obviously, it's kind of medical and lots of medical terms. Some of you will be very familiar and some of you won't be. It's easy to be overwhelmed by this information, but I think you just have to come back to, actually, this is sort of kind of a necessary evil that you have to hear stuff, so you kind of know what's out there. Some of it's relevant, some of it isn't. It's just important to know that if something's happening and you need more help, then there's got to be a pathway to get that help. So I am on, I have to sort of mention, I kind of have a few disclosures, if you like, and medical profession dealing with pharmaceutical companies is always an issue. The good thing is I don't prescribe. So geneticists do not prescribe drugs. I haven't written a prescription for over 20 years. So I can truly say that Novartis have supported TS hugely in terms of the development of medications, etc. But I personally haven't prescribed it, but I can sort of say that they've done a really great job, and not because I'm getting much more than just coming along to meetings and being able to educate people, which has been great. I'm also on the board, as mentioned. And since we started in 2005, and it's sort of almost 10 years now, we've run our clinic. And I only think sort of now I'm started in the last sort of 2 years, really starting to sort of kind of feel as though I'm on top of it. So it gives you a bit of an idea of how hard it is from a medical profession to feel comfortable that you know the broadness and the scope of everything in TS that you need to know. But as a result of that, we've now involved with a number of international multi-centre trials, and a lot of the information you're going to hear about for the subspecialists about the treatments that we can now provide in certain circumstances. Not everything, but some things it's really, really exciting. We are doing that. And so there's no reason why the same thing shouldn't happen in New Zealand. And I think that is hopefully what will come from a meeting like this, is the medical profession put the hand up and say, actually, I want to now be kind of the person locally who taps into this for the benefit of families in TS and other clinicians in TS. So what is TS? Many of you know this better than I do. It is an inherited condition. About 1/3 of cases, that genetic change happens as a new change for the first time, and our DNA is set up to have new changes. We're all stuffed full of mutations, all of us, but if you're unlucky enough to have a new mutation in a really important gene, then you can end up with a genetic condition. So it's part of the natural process. It's not something anyone did or didn't do. It's just one of those things. There's no control over it. That's about 2/3 of the time. About 1/3 of the time, a parent will have TS. Now, we see a lot of children with TS who are diagnosed. They may present seizures, will have learning problems, and that child's diagnosed, and then we look at the parent and find the parent has TS as well, and they didn't even know it. They may have been to doctors with various things. What are these bumps on my face? Or what is this white patch on my skin? And they've been basically missed as having TS because people don't realize that TS can be a very mild condition with just some skin lesions and not really much else. And so that's not an uncommon story, and I've already heard it twice today from individuals here. About 1 in 6,000 birth incidents, and a lot of these figures are very rubbery. Even across the world, people really don't have a good idea what is the actual incidence and how many people out there are there in Australia and New Zealand with TS. And so some people might say 1,000, some in Australia might say 2,000. I mean, we don't really kind of know because, in a way, when you think about it, what are we talking about? Are we talking about the severe cases? How many of those are there? And when we say severe, do we mean severe epilepsy? Do we mean renal disease? If you look at the whole, well, a whole lot of people with TS aren't even known to have TS because they're just out there in the community. So it's a really difficult figure to know, well, what is the actual figure? And I think with education, I think detecting people, even when they have mild forms of the condition, is so important. Primary care, that doctors know that, well, if you see someone with this sort of apparent mild problem, you don't just ignore it, you go further, because it is important to recognize an adult with TS because they need to have their kidneys screened. We don't want an adult to present with a big mass in their kidney that's bleeding and then may need sort of urgent treatment that will be more complicated. If TS is there, we want to pick it up early, we want to manage it and monitor it and minimize the impact of that. And of course, for a parent with TS, there is this issue about passing the condition on, but there's actually opportunities to avoid that if one wants to do that. So it's a variable condition. The bad, scary bit is the effect. It's the seizures and the learning problems, and that's obviously a huge impact. And we've heard a little bit about that side of things. And then it's also a condition where you can get growths in various tissues of the body. And we'll cover some of those things. So you probably can't see this, but these are sort of just a snapshot of the sort of parts of the body that can be affected. And Sam, you probably should come and sit over here so you can see, because I'm getting in your way. So these are the skin lesions. You can get little bumps on the scalp occurring, and they're there. They just don't need anything doing to them necessarily. Sometimes they're removed because they catch and people don't like them there, but generally don't cause any problem. You can't really see the facial angiofibromas here, but the bumpy rash on the skin, most people will have those sorts of skin lesions in time. And as you heard already, we now have topical treatment that, and we'll hear a little bit more about that later, to treat these lesions. So when you look at a picture of TS skin lesions on the net, you'll see this huge sort of disfigurement. We should never see that nowadays because we can treat it at the time it first comes, and that just nips it in the bud. So that's an extraordinary development, really, and we'll hear a little bit more about that. The first sign that we often get is the white patches. You can't see that. White patches are very common, and one of the common consultations for us or inquiries to the clinic is, does this person have TS because they've got white patches? And we get them in, and obviously as soon as parents look up white patches, they see TS and they're in a panic. And in fact, a lot of people I see with white patches don't have TS. And so that's an important part of experts. If you don't see the expert, then you may inadvertently kind of get miscommunication about what really is going on. And so I spend a lot of my time saying, well, no, actually, this isn't TS. We might do some further tests to confirm that clinically, but in fact, it's reassuring for family members to know that that's not really what we're looking at. And then the teeth generally aren't a major problem, but it is important to get the checkups, because the gums can overgrow and cause problems and bleeding. Sometimes there's little pits, so like all of us, we should get our checkups done. People with TS should get their checkups done. Little spots can grow on the back of the eye, which usually are not a major problem, actually. If they're there, they're usually just there, and they don't change, they don't grow, but rarely they can, but usually it's not a big deal. One of the major problems in the adults are the kidneys, and we'll hear a little bit more about that later, where you can get these either cysts or little overgrowth of blood vessels, a bit like, say, the skin lesions, but happening in your kidneys, but they have the potential to grow more. They're little fatty blood vessels. The lungs can be involved. I'll talk about that, cysts on the lungs, and rather like the bumps, but on the lungs. It's a similar sort of process that's going on. Some cysts in the bones, very rare. Sometimes you get lesions on the liver, again, very rare. And lastly, the brain, which is the real major issue. You get these little spots you heard about of the brain. So here's like an axial view through the brain going through that way using an MRI, and this is the right, this is the left. And you see these little high signal regions, and they're what we call cortical tumours. After a potato was just the pathological description of why people use the term tuber to describe them, because they looked a little bit like little lumps of potato, if you like, in the brain. So, and they're the little developmental anomalies where the message is to make the sort of normal architecture of the brain differentiate normally. They're the little clumps of neurons that haven't really got where they need to go, and they haven't really formed the way they need to form. They're just there, and these are thought to be partly involved with the seizures, but not necessarily so. And they don't grow, they don't form tumours. The tumours you hear about of the brain are along the ventricles here, so those little black slits you see here are the ventricles, because there's a circulation in the brain as well, where the blood gets filtered and comes out looking, and the cerebrospinal fluid's like gin, really. It's crystal clear, and it circulates through some chambers in the brain and then over the top of the brain and circulates. And that's what these structures are here. And what you've got a little along the edge of the ventricles, you get these little nodules, again, a bit like the skin. You might see pictures of little nodules. Often on the brain, they're there, and they just stay there, and they don't do anything. And we monitor them because sometimes they can grow. And if they grow, they can cause problems. They never grow so quickly that they cause problems in a week or a month. They're usually growing over a long period of time. So it's not a sort of urgent situation to do anything if there's one is growing. It's a way of deciding, should we do anything about that? And when they get really a little bit big like this one, they can block the normal channels there, rather like the plug is in the bath, so the bath fills up. And that's what we want to avoid. But that can take months, if not years, to develop. So we've got a potential by monitoring, we can intervene and then stop that happening. So nobody with TS should ever present with fluid on the brain like this, hydrocephalus, if we know that that's their diagnosis, because we should monitor it. It's and you definitely don't want to get to this stage, because it then leads to, them potentially harder to treat. The other thing to notice that this is just a timeline. So during the pregnancy or before pregnancy, geneticists often get involved to talk to people about what implications are if they have TS and they're wanting to have more children, or even if they themselves as a parent don't have TS but they want more children. What are the chances of something happening again if they've had a child with TS? And because it can be such a variable condition, even within the same family, you can have somebody who's got sort of relatively little or hardly any problems, and then up pops somebody who's got major problems. And so it doesn't sort of breed true, if you like, which is the scary thing. And then the sort of things that can happen in TS can happen at different ages. And so it really depends when you're seeing the individual is what you look for and what the chances are of being able to diagnose the condition. And so we're now seeing, fortunately now I think, we're seeing less people presenting late in life because of bleeds from the kidney lesions, because they've already been diagnosed. We're seeing less people presenting with intractable seizures long-term and hydrocephalus because we're monitoring for it. And what I'm seeing now is a lot of babies being detected in utero because they get the little bumps appearing on the heart, in the heart. And actually, interestingly, those bumps called cardiac rhabdomyomas are very common. About 60% of babies who have TS will have those lesions on their heart that can be seen with ultrasound. And they will just disappear in time. So clearly there is a biology within TS where naturally the bumps disappear. That's not without treatment. It happens naturally. So that's part of our wanting to understand that process, because if we can tap into that, there may be all sorts of other treatments that we may be able to sort of provide to sort of not only make the lumps shrink, as we can do that now, but to actually make them go away, because the cardiac lesions go away. Okay, so that's not unachievable. I suppose that's an important point. So I'm seeing a lot of babies who we already know they've got TS because they picked up this on the ultrasound, and that's challenging as well for imagine a family being diagnosed their baby and you haven't even had the baby yet. So, what that means is that group of children that we see at birth, we don't have to wait till they're presented with a problem. We will monitor them very closely, and we do not. So nowadays we're very active about looking for seizures. We don't wait. If we know someone's at risk of seizures, any little thing that is a worry, and we talk to families about what to look for, those little spasms you saw were subtle enough to say, well, it's nothing. The GP said, don't worry, it's nothing. Because babies do little things like that all the time. But if you've got someone with TS who's doing anything, then that's kind of like a medical emergency. Because the sooner you treat those seizures, the better outcome it's going to be. And what we're finding is, and we're waiting for the evidence to come through, but we should not see individuals who have had untreated seizures unrecognized. That should just not happen nowadays. And so we do EEGs, even if a baby doesn't look as though they're having seizures, we do an EEG because you may pick the electrical activity before you get overt seizures, and we would treat that. And some people would even, and a study is being done at the moment, even treating all babies with TS at birth if you know they've got TS because of the high risk of seizures, to see if you can actually improve the outcome. That's slightly more controversial, but what we do is we do EEGs, and at the first sign of an abnormality on the EEG, we will treat them with a Vigabatrin, which is a really good drug for that. So I'm going on and on, aren't I now? Yeah. Okay, so I'm just going to give you a little bit of a history now. And this is a condition we've known about for a long time, back in the 1800s. And a few individuals have come along and sort of described some of the medical associations of the condition at various stages. Bournville was the one who described the tumours. And then a lot of medical students and doctors still have this idea here, 1908. This is what, if you ask most doctors who are now currently practicing, what about TS, what is it? They will say it's a condition that causes that rash on the face, epilepsy, and intellectual disability. That's what they will tell you, okay? They won't necessarily tell you about all the other things that you know about. And that's a real, even today, that's what people will think, which is appalling. We're trying to make inroads into this, and I think we're being very largely successful. But this is Gomez was if you like, the grandfather of TS, and set up a clinic at the Mayo Clinic, and wrote this extraordinary book on the condition back in 1967. And then things have really changed, and I think this is the disease that other rare diseases should model themselves on. And so, although you're in this room because someone in your family or you have TS, it's a very much better situation for you than it is for all those other genetic and neurological conditions I see. Because this is one where we've got information, we sort of know what causes the condition, and we've got some treatments coming. And that's what will happen for all those other conditions, because that's where the science is at. But this one, we're already there. And so that is a unique situation. So we had the genes that were discovered back in the 90s, and that's the first start of trying to understand the biology. Well, it's a genetic condition. Well, what do those genes do? And why is it people get the sort of problems they do? And why is it some people have more problems than others? And how can we target things and if you like, give a personalized treatment, if you like, for individuals? And it was the game breaker, really, was when we started to work out, well, what do these genes do? And I'll tell you a little bit more, and it's this pathway called mTOR, mammalian target of rapamycin. So our cells, basically, when we're first conceived from a fertilized egg, we have to grow into a complex person. So every cell has to copy all the genetic information, and every cell then copies it into another cell. And so there are mechanisms within the cell to make cells divide and grow. And what this condition partly is an abnormality of that process, which should have stopped. Because this pathway is working in all of us, and when we were first conceived, it was very active in terms of making everything grow. So there's systems in the body to make that happen, but then there's systems in the body to slow it down and stop it when the time comes. So there's a lot of complexity there. And so, and the area that's really kind of helped us understand this is the area of cancer. Understanding what are the pathways within each cell and within each tissue that control that. We're learning about that by people who've developed tumours, and you say, well, what's going on with that tumour? Well, it's multiple pathways that affect growth that lead to a cancer. TS is actually not a cancer condition. It's actually just one pathway within the cell that's overactive. And so really cancer is not such a big issue in TS. And so when we say tumours, we don't mean cancer. Cancer is when there's multiple pathways affected, and those cells are really going out of control, and they can start spreading. That doesn't happen in TS. But the pathway is much more complex than you've seen. But basically, here's a cell. There's various receptors on the cell, various things like growth factors and what your diet is, etc., and that sort of thing. They've got to communicate within the inside of the cell, so there's a mechanism of receptors, communication and signaling relaying through various signaling pathways. And TS is the TSC1 and 2 genes. They make proteins which coalesce and join together in the cell and act as an inhibitor of this pathway called mTOR. It's way more complex than even this slide, and I'm going to simplify it for you a little bit. And even now, where there's another component of that complex that's been discovered, and there's a lot of research looking at what does this protein do. I'm going to just go straight to this slide. So this is the simple slide about what this is. So here, what a gene does is make a protein. The proteins are called hamartin and tuberin. I've just used the gene name there, but basically the genes make these proteins in every cell of our body. They join together in the cell and have an important role to stop mTOR, or if you like, dampen it down, because it's got to go, and it's got to go. Sometimes it's got to grow, sometimes it's got to be less active, because it's a normal part of the functioning of the cell. Okay, so our mTOR pathway is happening for us all the time. But what happens in TS is that because this complex isn't working properly, you don't get this normal suppression, if you like. And so, if you like, the brakes are off, and so you get overactivity of that pathway. Okay, and then that in the skin and the kidney and the brain lead to those growths. In the skin, it's predictable. It will happen in most people. In the brain and the kidneys, it may not. There are other factors that influence that. For the skin, it's the sunlight. So the more sun exposure you get, the worse your angiofibromas are. So that explains that bit. So that's why the putting sunscreen on is such an important thing for everybody, because sun is damaging cells in all of us. The more sun exposure you get, the more aged your skin becomes. And so for people with TS, they're more susceptible. If they get damage, then they can damage this pathway, which then leads to the angiofibromas. So, and that leads to tumour growth, whatever tissue it happens to happen in. Now, the game breaker really was when we kind of found out about this group of drugs called mTOR inhibitors. And in fact, this group of drugs, and the reason I should have showed you the statues on Easter Island, and it's really important that this is a Pacific island where actually the medicine that is now being used to treat tuberous sclerosis came from Easter Island, Rapa Nui. And the medicine is called rapamycin. And it was being used for the last 25 years in individuals who've had renal transplants because it's a drug that's immunosuppressant. In other words, it dampens down the reaction, the rejection of renal transplants. So it's been used by kidney specialists for many years, and there's lots of data on it, you know, in adults, not so much children. And so when it became clear that actually this drug targets this pathway, which is actually the bit that's wrong in TS, people thought, well, maybe we just use this group of drugs in individuals with TS and see what happens. And in fact, what happens when you treat tumours with mTOR inhibitors in people with TS, the pathway basically dampens down and the tumours shrink. So that's the simple biology. And nowadays we've got sort of zebrafish and Drosophila, so we can do all sorts of little experiments on animals to sort of work out the biology of that, and then that's led to all sorts of interest in this pathway in tumours, but also this is a pathway that's involved in obesity. So this rare disease is actually a disease that's relevant, and there's knowledge. If we understand this pathway in the setting of individuals with TS, we may actually understand more about more common conditions such as diabetes and obesity. So obesity may be an aberration of this pathway in some individuals. And some cancers, this pathway is a major component to those cancers. So there are some breast cancers and other tumours where we profile the tumours, and we can look at the tumour tissue and then see which pathways are involved, and then we can provide the treatment that treats that cancer in that individual, not just the cancers generally. So it's personalised medicine. And then that's the tumour side of things, but also this pathway is involved in brain development. So that pathway, it's not just all about growth, it's telling where those cells have to go and what they're meant to do and what type of cell they're meant to become. And so it's not, and we're still trying to work out a lot of the biology here, but it's clearly important for brain development because people with TS may have severe seizures and cognitive problems. And it has, so it's really got widespread effects. And if we understand the more about mTOR and how it relates to epilepsy, maybe we'll have treatments for epilepsy outside TS. So again, the concept, this condition may lead to advances in treatments for really common conditions. So investing time and effort in that, in this condition, may benefit the wider society. It's a really important concept that the health providers and the governments realise that. And similarly, autism. But autism is very common in TS, much more so than the general community. And so why is that? And there's lots of studies trying to understand that. So it's realistic to think there may be treatments for all these sorts of different effects: autism, epilepsy, intellectual disability, whereas it used to be, you're hardwired, there's nothing we can do, we'll manage the consequences. But in fact, I don't think that's true. And increasingly, we're getting examples of that now. And then obviously our friendly mouse, we can do all sorts of things to the friendly mouse. Before we get to humans. And so the next game breaker was in 2006, where all this work was done on animals, systems, showing what the pathway does, get tumours. If you treat mice, what happens with TS? Can you make them better? And there's all sorts of really positive information. But the kind of thing that really changed things initially from the use of rapamycin was David France. He had a series of patients who'd had the SIGAs, and here's a picture of one of those. You can see those slit-like structures, some of you at the front anyway, are really big. And there's this big white thing here, the SIGA, which has blocked off the circulation there of the fluid. And that's sort of, if you present like that, you've usually got a bad headache and you need to have an operation. But he had a series of patients who had had tumours which had grown, they'd been operated on, and they'd come back. Or another tumour had grown somewhere else. And so he had a handful, 5 or 6 individuals where he really couldn't do anything more. They couldn't do more surgery. It was just impossible. So he said, well, there's nothing else to do. I'm going to try this mTOR inhibitor. So he was groundbreaking, and he asked the hospital ethics committee, are they happy for him to do that? Because clearly, suddenly treating these drugs in mice is one thing, but when you're using them in humans. But we had human data. That was the important thing. And so there was really no reason why he couldn't try this. And he tried it, and all the tumours shrunk to at least 50% of their size. Now, that's the other important thing with this condition is we're not aiming to get rid of the tumours. Oh, that'd be nice, and one day we will be able to do that. But what we're wanting to do with a big SIGA like this, we want to shrink it so then the fluid can flow and the symptoms go away. And we've got many people who are on mTOR inhibitors now where everything's working fine. The SIGA's stable now, it's smaller, and we just keep an eye on it. No big deal. Same goes for the kidneys. And when you stop the rapamycin, though, it grows back. So there you've got the situation is how long can we leave someone on rapamycin? And it's not something like a cure. Take the antibiotics 10 days later, it's cured. It's not like that. You need to take it long term. And then as a result of that, a whole lot of studies were done, and Everolimus, which is the other form of the mTOR inhibitor, sirolimus or rapamycin is the initial one. Everolimus is the drug that Novartis have developed, but essentially they're very similar in terms of the components of the drug, the chemicals of the drug. And Novartis have put lots of money into clinical trials, which have been really good clinical trials. And as a result of that, this drug's been approved for SIGAs in Australia and the US and in New Zealand for SIGAs, particularly SIGAs, and for us, angiomyolipomas, and for LAM, which is the lung involvement, in TS, but not sporadic LAM. So, and 2013, that happened in Australia. And that's extraordinary. There was one study on the SIGAs that was for 28 patients that was written up and was in the New England Journal of Medicine. And as a result of that study, because it was so well done and the evidence was so clear-cut, that led to approval. And that's really unusual. But that's the strength of if you like, the effect. And as a result, this is the listings in Australia. And the important thing is here, it was for SIGAs, which are the subappendable giant cell astrocytomas, that's the name of them, or visceral tumours. And that is I don't know who did the wording, but it was very clever because it gives scope for other indications, not just AMLs, not just LAM, but things as well. And I'm hoping that as we get more evidence, this wording will change to account for those other indications without having to start off all over again. And so because you've got to if you're going to put money into development of drugs and treatments that work, you've then got to have a system to get those drugs to the patients who need them. You cannot have a block at that point. It's so important. As all this was going on, we had a whole international group of TS experts in the first consensus meeting in 1998, which kicked everything off. And I wasn't really involved in any of this, and it really was 2005. Just before this, we started to get interested in this. We had David France come over to our conference and talk about this. And then we had another one in Washington in 2012, which is for each, we had about 10 or 12 specialists for each different branch or subgroup of the clinical effects of TS. So I was on the genetics one, we had the SIGA one, the epilepsy one, the ring one. So there was about 200 specialists altogether from all over the world, and our job was to rewrite the diagnostic criteria and the management recommendations, treatment and surveillance recommendations. That's all in your handout. Those particular publications, and this is the kind of the diagnostic criteria. And the only thing that's different, a lot of these are just the things that clinicians like I look at to see, well, does this person have TS or not? And I gave an example of that with the white patches, didn't I? And but it just allows us, can we make the diagnosis? Okay. The thing that was different was the use of genetic testing, which previously wasn't there, but genetic testing is much more available now. I tend to be an advocate of that because I think it's really helpful in a couple who've got a child with TS. If you can find the mutation, then it just clarifies everything really nicely. You can do the parents quickly. It doesn't take a year. Once we know the mutation, we can get the parentals, 2 or 3 weeks later if need be. And then it allows you then to use that information. And as a parent, if you've got TS and you know the mutation, then you can access IVF and pre-implantation genetic diagnosis and select embryos without TS. And so it's helpful in couples who are reproductively active. And I think also the other time is when it's siblings. So if you've got a genetic test and you've got, it appears that individual is the only person in the family with TS, and we've proven that. When the brothers and sisters are getting older and everyone gets a little bit anxious about TS, and how sure are we that somebody else who doesn't appear to have TS, may they have it because of that situation where the symptoms can be very mild. Well, I often will just use TS. If I know they've got the mutation, I'll just test them at that stage. I won't usually test young children. I'll talk about that in a minute. And that's to restore their confidence, because the impact of genetic conditions is huge on not only the individual, the family, but the wider family. And if you don't get that concept, you really understand that when you have a family meeting, and you can see that everyone's invested in knowing more about this, and so it's not just an individual family; it goes beyond just the parents themselves. And I'll just get onto this, which was this sort of what do we recommend are the current surveillance and management guidelines. Now, these were put together incredibly carefully, and it was all based on evidence. So to be able to achieve anything, you have to prove it. I'm an enthusiast, and if I go to somebody and say, look, it's a no-brainer, look, you need to fund this, people kind of listen to me nicely and they go, but you're an enthusiast. Of course, if I believed everything you say, I'd fund it. But you have to have the proof, and so when these recommendations are relatively conservative because it was what was the evidence in 2012. So even now, the evidence is different 2 years later. So this is something that we're going to be updating this, because we have to keep on to be able to advocate for families in different countries. We need to have evidence. So you go along to the health providers and say, well, this is standard of care. We're not doing it. Why not? So you have to be able to have something to use when you're negotiating these things. So just to go through this, there's again long lists goes through all the systems, and I'll just go through them one by one. But that's the sort of the summary page. So just give you a sense of it, really. Sort of so these are the consensus guidelines with some of them high levels of evidence, sometimes just expert opinion. So what surveillance should we do? Well, in an individual who presents where you're considering the diagnosis of TS, obviously you do an MRI if you can. Most places you can get an MRI nowadays in the developed world. It's the best test to do. And individuals who have a SIGA may need to do more frequent MRIs to watch what's happening to that. So we've seen a few babies now we've picked up with the heart, we've done the MRI, they've got a SIGA. And the definition of a SIGA is when that spot is really just grown to about 1 centimetre. It doesn't mean magically it's turned into this horrible tumour. It's just a size thing. It's not a cancer. And so some of those babies, potentially we could have thought about treating them with an mTOR inhibitor at that stage, but in fact, they were asymptomatic, and what we've done is we've watched a few of them, and they've just stayed that way. And then the baby's grown, and the brain's grown, and the SIGA's stayed the same. So some SIGAs don't grow. So understanding the biology of that is really important. But we watch the babies with head ultrasound, and if it's growing, we know there's trouble brewing. So we'll treat. And the treatment currently is an mTOR inhibitor rather than surgery. And we've got people who've been on mTOR inhibitors in that situation for a number of years. If somebody presents with a big tumour and hydrocephalus, you can't treat them medically at that stage because it's too urgent, because the treatment only works relatively slowly. But if you've got an acute situation, they need an operation. But hopefully, as I said before, that shouldn't happen nowadays. For seizures at diagnosis, we need to be very active looking for seizures in the young children and doing an EEG at diagnosis, especially in asymptomatic infants. So we don't wait for the signs. And doing these prolonged EEGs, sometimes telemetry, we get people in for a few days and that sort of thing and see what happens while they're asleep. Because a lot of seizures may happen at night or when they're asleep. And if you just do, just a snapshot EEG may not tell you what you need to know. But a specialist neurologist needs to be involved with all these cases. The TAN, which is the Tuberous Sclerosis Associated Neurodevelopment Screening, that's really a conversation, and again, the checklist is in your handout. Every person with TS has a slightly higher chance of a range of mental health issues. So even individuals who are actually very cognitively normal, they may have a tendency for anxiety disorders above and beyond the population, and subtle learning problems. So we shouldn't necessarily concentrate on individuals who have really major learning problems. We should concentrate on people who have normal learning, but maybe some specific areas they're not so good at. We should be really actively looking for those things. And again, we do neuropsych assessments on all our children. And then this is the treatment that I talked about, is once you find it, then it's kind of, is it surgery, is it medical? And, it's weighing those things up, and I can't give you you're going to hear other things about that later. Epilepsy, again, I don't treat the epilepsy, but there's a range of treatments for epilepsy. Vigabatrin's good, there's a range of other anticonvulsants. Sometimes surgery is an option. So in some circumstances, that certainly is an option. For the kidney, they recommended that MRI should be done to monitor the kidneys, but clearly not everyone can get an MRI. So ultrasound, I think, is good enough. We tend to use MRI. Certainly if someone's having an anaesthetic to do an MRI of the brain, we'll include the kidney in that. It makes it about a half an hour longer, but it means that we get better pictures and it's easier for the family, and so we do that. But there isn't a Medicare item number for that, so that's a problem to get it funded. And then monitoring the kidneys and monitoring the blood pressure. And then if you've got angiofibromas, well, and this is changing currently, is when do we treat? At what size do we treat, and why are we treating? And so John Bisler in Memphis is kind of looking into this and has got some amazing data, we're generally thinking we probably should be treating a little earlier than we have been thinking about. But it's evolving, a lot of this data, and you'll hear about this. It'd be interesting to hear what's said in the sessions this afternoon. And then the lungs, and I won't go through this in any more detail, except, the lungs, we refer all our females to see a respiratory specialist to have a high-resolution CT at 18 years of age. There are exceptions, but mostly you're not going to run into any problems with the lungs before 18. But it's really important. The LAM or the lung problems are there if you look hard enough in males, but it doesn't cause problems. And it's obviously related to hormones and that sort of thing, that why females can get the progressive disease that can lead to the cysts on the lung and then the tumours and then the sort of respiratory failure that can happen. Sorry? Okay, 10 minutes, yeah. Don't worry, I've almost finished. We also let the cardiologist monitor the cardiac rhabdos if they're there, and usually they go away. But we then have another look in the teenage years, because some individuals with TS can get some rhythm disturbance. So where the rhabdos were and they shrink away and disappear, they can interfere with this sort of normal heart, the electrical signal in the heart. So there may be, individuals may be at risk of palpitations or slow or fast heart rates. And so anyone with TS who's getting any of those sorts of symptoms, they should definitely have them looked into. But we routinely do ECGs in the teenage year and have another look with an echo just to make sure at that stage. And then the skin and the dental, which we'll hear about those sessions later. So you get a sense of the way that's sort of that information there. There's lots of things on there. Not everyone with TS have all those things. Some do, some are unlucky, but most people don't have all those things. But each of them, the team who are, if your doctor's looking after you, they need to be aware of all these things and then be referring to somebody who can give you advice on the specific area if need be. So this is kind of a concept slide about the cognition side of things, the intellectual disability. So that's just number, and this is IQ, and this is the general population normal distribution. These are the average people. I don't know where I am. I'm probably about here above average. But I know people up here. It's scary. And then some people who have trouble. But that's the normal population. In people with TS, many people with TS have a normal IQ. It might be shifted a little bit to the left. Okay, so at least 1/3 of individuals, maybe more, have a normal IQ or above. Okay, there's a professor of genetics with TS, and in fact, Vicky Widmore, who's the editor of the book, she has TS, and I mean, you will not meet a smarter person than Vicky Widmore, and she's got TS. Her story is extraordinary. And then there are individuals who are really bad. Now, I think the people who are really bad are the ones who've had seizures that have been left unrecognized, untreated for months and months and months. And that's why they're there, because there's damage comes in the end. That should not happen nowadays if we diagnose TS quickly. We can make this disappear, and hopefully we can make this shift back with good care. And so the impact on the health system of somebody who shifts into the normal range is huge. So that saves money and helps families. This is the TAN checklist, which is, I won't go through, but it's just looking, it's really important that you don't forget about all these sort of behavioral issues, psychiatric issues. I mean, families know this better than me. The behavior side of things can be very difficult. And we do not have an answer in our center either for this. And you need to just be linking into who are your best mental health providers locally. But what you can do is you can educate those behavioral psychologists about what we know about TS and give them information so they don't feel as though in some ways the TS means that they're not going to be successful with the standard programs, because they will work. But sometimes people get a bit overwhelmed by an individual with TS who might get seizures, and then they kind of forget actually they still have to do their job. And they feel as though somehow it's not something that's going to respond. Well, that's not true. And this is what that TAN checklist looks like. You're going to get a session on genetics, so I won't go into that, and I talked a little bit about that earlier on. The important thing about the genetics, and the reason why I'm an advocate for the genetics also, is because I think when we start teasing out the individual mutations and within which gene, we may start to understand why one individual may have a slightly worse case of a particular problem. And we're already seeing that in TSC2, individuals, as a group, there appears to be more intellectual disability. Having said that, the most severe individual we have in our clinic has a TSC1 mutation, and we have many, many individuals with TSC2 mutations who are cognitively normal. So I know when parents get results and we find it's a TSC2 mutation, they go, damn. But in reality, it doesn't tell us that much. And I know but I think overall it's better to know what you're dealing with at some stage. And particularly, the data is there with AML. So if you look at the AML data, you can see that individuals with TSC1 mutations are at much lower risk of developing bad renal AML disease. So that immediately tells me, if I know someone's got a TSC1 mutation, they're really not going to run into problems with their kidneys or their lungs as a female. And that's quite helpful to know that. You know, if you've got a daughter with TS, and it's a TSC1, I think I'd like to know as a parent, you know, do I really have to worry about the lungs as time goes on? And so I think we need to be doing genetic testing, and there may be all sorts of other subtleties that we can find when we start looking, but because people haven't been doing a lot of genetic testing, they've not been looking at the data, and so we haven't been getting the advantage of that data. So I think now genetic testing is actually becoming much more available and cheaper. So I think we're now in the era of doing that more often. So lastly, I'm going to stop. I just mentioned a few people. So we have a pediatric TS clinic. If you're going to have a multi-D clinic within a centre, you just have to need people you get on with. And Jackie helps coordinate that. A cheap way of providing of trying to get these things working is all these specialists, what they worry about is it's going to be a huge administrative task for them managing this. It frightens them. So the cheap person that hospitals can provide is a coordinator. And that has to be maybe nursing, not medical, because they're more expensive, but somebody who will actually just make it happen. And so we now have, Jackie used to do this on top of all her other jobs, but we now have a really smart neurology secretary who was just typing letters and things, but she was much better than that, and she's helping us coordinate this. And it's just like a weight is lifted off everyone's shoulders, just having the right person to manage it. And then she just everything else then flows from that point onwards. John Lawson's the pediatric neurologist. I mean, he is the Australian expert on this. Anyone who's got a question about TS, I'm talking about the pediatric neurologists in Australia and New Zealand. If they've got an issue, they should be talking to John, particularly about the use of mTOR inhibitors, because there is data now and trials that are currently underway looking at the use of rapamycin for seizures, and the evidence looks good. And we've got about 14 people on Everolimus or rapamycin for seizures, and in some individuals it's extraordinary, the effect. And we've done one publication, and David France published his series. In 20% of his case series, these were the baddest of the bad individuals with epilepsy for years and years and years on 4 or 5 medications. 20% of those individuals became seizure-free. Okay? Over 90% of them had a 50% reduction in seizures. So I reckon most parents would pay that. If they got that effect, and so it's huge. It's clearly not the whole story, but it's huge. Sean is the nephrologist, and the good thing about Sean is he sees adults as well, because the major issue here is pediatrics, adults, transition. You can put all this in place, which what we did, but you're failing families if you don't then help with the transition process. And we are still struggling 10 years late after doing what we've done. We've tried to set up an adult service, and we've been only partially successful. And I would say we've been trying really hard. So this is a huge task, and it's really a shame that this happens. But we're still trying to advocate to getting a similar adult service. What happens is I refer to the neurologist. Sean sees them. I refer to Deborah Yates, who's the lung expert at St Vincent's. But I can't get these people come to one place in a clinic, because that actually, the way I think it works best, people come on the clinic day. We have about 10 patients come. They see every specialist. It takes all morning, but it's done. They're not seeing 10 or 20 specialists at different times, or appointments spread through the year. Clearly, people still need to see their neurologist if the seizures are bad and all those sorts of things. But to get all those people and everything on track, and are we on top of everything, set the pattern for the next year, it can all happen in one day. I think we're successful at that. I don't think it's perfect because it's hard, but we're still trying. And our laboratory is also very helpful. And David France has been extraordinary. He's come over a couple of times for conferences, and he's been really helpful. And Darcy Kruger and Hope Northrop were involved in the recent publications at the consensus meetings. And of course, the TSA, which was actually at that time was a combination of Australia and New Zealand, they have put in big bucks to help various studies, and we'll hear about the treatment study. But I think this should be a journey between support group, pushing hard, government, federally, recognising this is a big issue, and clinicians. And between us, we've just got to get a model of care that works. Our model of care, I think, works for us. It may not be that's needed to happen here. It's really more knowing who are the experts locally. Okay, I'm going to stop there. Thank you very much.